Hold on, should we be using isometrics for tendinopathy? And this is some really interesting research that's out there. Let's talk about isometrics, how they can be used for tendinopathy, and spoiler alert, it's not a one-size-fits-all approach. Now, back in 2015, Ebony Rio had a groundbreaking research article that created a lot of attention in the British Journal of Sports Medicine. Basically what it said was that isometric holds relieved pain for tendinopathies, and it provided immediate pain relief. Now, since then, there hasn't been a lot of research that's been able to support that. However, there's a lot of reasons for these mixed outcomes, and the fact is, treating tendons and using progressive tendon loading is multifactorial. There's not a one-size-fits-all approach, and let's talk about how we can tailor it to our patients to be able to get them the best results. So, basically what Ebony Rio found was that isometric holds of 5 sets of 45 seconds at 70% of their max volitional isometric contraction provided immediate relief. Now, what they have found afterwards has been that isometrics benefit some patients. Some patients don't benefit from isometrics. And really, we should be starting isometrics and isotonics right away for patients with tendinopathies. But it really comes down to the fact that there's 4 different types of load for tendons. And those 4 different types of load are going to help you decipher which type of exercises, which program, which progressive tendon loading you're going to do. And what we really want to be careful for is that there are peritendinitises out there. That inflammation is of the tendon sheath. We need to be careful of that. And if that's inflamed, we do not want to start isometrics or isotonic exercises. So let's specifically talk about the 4 types of tendon loading. And that would be compression, tensile, combination, and friction. So let's get into each of these. Now, the reason why this is important is because we need to know how the tendon is getting inflamed. If we know that, we're going to be able to then treat it much better. So compression is going to be the tendon getting compressed and smashed against the bone. Think of the Achilles. In extreme or end ranges of dorsiflexion, the Achilles is going to get smashed on the calcaneus. Especially for insertional tendinopathies, insertional Achilles tendinopathies, we're going to see an increase of symptoms. Now, those patients, we want to be very careful to keep them away from that end range and aggravating their symptoms. So another example of this would be adduction, compressing the gluteal tendons on the greater trochanter. That's another good example of a compression load on a tendinopathy. So in this case, we'd want to keep them out of that range. Now, tensile loading is going to be load that's put on the tendon that's going to be essentially a faster rate of speed. These folks are going to have symptoms with loading, especially at high rates of speed. So in this case, they're going to have increased pain, and this is going to be an example of like jumping in place. Basically, that energy storage and release is what's aggravating symptoms. For those folks, we're going to be careful with how much and how aggressively we load that tendon. And then most commonly, you're going to have a combination of the two. It's going to be compression and tension forces. Because what ends up happening is that we play sports, we go run, we go do all these things in our everyday lives, and that is a lot of different factors that end up causing pain, causing symptoms. So that would be like running uphill for Achilles tendinopathy, also running uphill for proximal hamstring tendinopathies as well. This would also be running downhill with excessive hip adduction for your gluteal tendinopathies, and potentially running downhill for your patellar tendinopathies too. All those things in mind, we want to tailor what progressive tendon loading we're going to do, specifically if we're going to provide isometrics or not, to our patients. And then lastly, let's talk about the friction load. So friction is going to be repetitive movements irritating the tendon sheath. This is peritendinitis. This is peritendinopathy. This isn't tendinopathy. So these patients are going to importantly come off load. They're not going to respond to isometrics. They're not going to respond to isotonics. And a good example of this would be cycling. It's a repetitive motion. It can get inflammation. There's some other criteria that's going to include here. For example, it's going to be more diffuse pain. It's also going to be pain that's not as associated with activity. So when you ramp up your activity, oftentimes tendinopathies go away after a little while of being active. These peritendinopathies do not go away with more activity. They actually get worse. So we need to watch for those symptoms. Now let's talk about how we can use these different loads. Now, it's really important to think about how we're using and how we're deciphering our different tendon loads, because the key is to give patients what they can tolerate. And that really comes down to being able to give them things that are going to not irritate them too much, and it's going to help progress their capacity to be able to do all the things you want them to do and ramp up the amount of capacity the tendon has to be able to tolerate activity. So here's a really nice diagram that you can use. We break this into things like frequency, duration, loading rate, intensity, and joint angle. So remember our different compression types or our different load types. All those things are going to be influenced here. So for example, you might have some symptom relief with a patient doing isometrics. Great, keep doing that. That's going to help them. That's going to make them feel better, especially if you can use it to modulate pain. Fantastic. But let's say that that pain is causing, or that exercise is causing them more symptoms. They're doing a 5 set of 45-second holds at 70% max volitional isometric contraction, and they're getting pain with that. Well, then you want to take them off that. However, you could play with other things to see if different aspects of progressive tendon loading might change it or might help them feel better. For example, you might have them slowly contract into that isometric hold. You might bring down the amount of contraction they're doing. So instead of 7%, you may be giving them 50 or 25 with a slow ramp up. You might have them do 30 seconds or 15 seconds instead. So you can play with those variables. You also might change the frequency or the joint angle. Maybe you are having them do that in extreme plantar flexion, and now we try it in the mid-range and it's actually feeling fine. Or potentially you are changing the duration. You're going to have them go for a shorter period of time, or frequency, not as many days in a row. So all these things can change. Also, isotonics can be started immediately for tendinopathies. They have good value and good benefit, and there's really good evidence behind it. Basically, in this case, what we want to do is we want to ramp up how much patients are doing, and we want to increase that tendon load capacity. However, in this case, again, be careful. We want to be careful to avoid end-range dorsiflexion for Achilles tendinopathy. We want to not do decline single leg squats for patellar tendinopathy. We want to be careful with our hip adduction angle for gluteal tendinopathy. We want to be careful for our hip flexion angle for proximal hamstring tendinopathies. Now we can also change all of these different dynamics, these different variables, these different aspects of progressive loading, and we can give patients a tailored approach. That's really what it is. We want to give people something that they can tolerate and then inch them further and further and further. For compression and tensile, be very careful of your loading rate, be very careful of your joint angle you're doing this in, but you can progress these tendons to be able to get better. And then lastly, how do we decide how much pain is too much pain? 0 to 3 out of 10 on our pain rating scale is what we go by. That's a fine level for patients to be within, either during the activity or 24 hours afterwards. But we want to be careful if those symptoms are getting progressively worse. We also want to be careful if they're extending that time beyond 24 hours. All those things can help guide us. Now, really what we want to do is make a customized plan for every patient that's going to be their method and their way to get better. Again, progressive tendon loading is going to be a progression of slowly adding more load to help the tendon adjust the capacity that they can tolerate to get back to all the activities. Use these variables, help patients get better, and use your clinical judgment on what patients are presenting as and how you can get them better by adjusting each of these variables.